This is a straightforward demonstration of a cataract extraction with an IOL implant and a Hydrus stent at the time of surgery. There you're going to see the 1mm diamond blade creating that paracentesis. I then like to use lidocaine for all my patients, mainly for comfort more than anything else, especially in the MIGS procedures. That little bit of lidocaine can make things a whole lot easier on you. I then like to use Viscoat to deepen the anterior chamber and coat the endothelium of the cornea. This provides nice protection for the actual phacoemulsification steps of the procedure. Here I use a 2.2mm diamond blade to create a pseudo two-plane incision. I then use that same diamond blade to start my capsulorhexis. I then bring in a pair of micro Utrata forceps. I'll continue this capsulorhexis in the best possible circle I can. Usually takes about 2 to 4 grasps to completely create that rhexis, and here you'll see me very slowly doing that. Nice rhexis there, completed. I then like to use the chain cannula to do my hydrodissection. There was a brief moment there where the patient was moving, so I just cut out that section of the video, but usually I do a technique called the nuclear slide. So I inject that balanced salt solution, I watch for that fluid wave, and then I go to the opposite side of where I started the fluid wave and just push down and over, and that usually releases the cataract completely from the capsule. It makes the hydrodissection very straightforward. My secondary instrument is a conner. It's kind of just a ball tip conner. The tip is protective because I like to go posterior to the cataract and then pull anteriorly when I'm doing my chopping. So I start with a sculpt there, creating 2 different hemisections, and I slip that conner behind and I pull forward. Sometimes it doesn't actually crack that kind of heminucleus, and so if that's the case, I just continue to take it out from there. I don't go back in and try to re-chop it. If you're real careful, these come out real nicely with very low phaco energy. And so there, first hemifield's gone. I'm going to rotate that lens, give me the second hemifield. I'm just going to pop this one right forward, not even going to bother trying to chop it. And then we're just going to use kind of light phaco energy. I like to do the hand piece wiggle. I think it helps. And there, nucleus is out. We're just left with our cortical material. We're going to come in with IA and just clean this up in kind of a circular motion. I like to kind of move more clockwise, starting just subincisional and then working my way all the way around. And if something doesn't come off on the first try, I usually continue to move around the circle, and that just helps free up everything. So I can always come back to an area if I need to. There you go. Cortex is now cleaned up. I'm not much of a polisher. I kind of believe the YAG laser is the best polisher around. And so here we're going to inject ProVisc into the anterior chamber. That's going to allow us to throw this lens right into the bag without having it grab anything. Your patient's jumping around again. And so once I get this lens into the bag, I'm not going to really mess with it. I'm going to let it unfurl while I do the actual Hydrus. And so usually I would go in there and I would make sure that those arms open up exactly where I want them to, but I know that I have enough time doing the Hydrus that those will open up and I can check them here at the end. And so here I always test the Hydrus, so I advance it first, make sure that it's moving through the injector without any difficulty. I then like to create a small goniotomy and work through that goniotomy. I usually do my Hydrus through the main wound instead of creating a second paracentesis, and I'm very particular about putting the Hydrus in an inferior nasal location. And so here I'm going to start injecting, and then once it comes through, because my angle is a lot steeper than if I was using a different paracentesis, I relax off the Hydrus and kind of push back a little bit, and that allows the Hydrus to bend around and go into the canal. That first attempt, I didn't like the way it was going in, and so I'm going to create a different different otomy site about a clock hour away, and I'm going to redo it here. And here you can see me backing off and allowing that to move forward, and then I bring the hydrus back in, I close it, and then I advance the hydrus just with the injector, and that usually does a real smooth hydrus for me. Here we brought the patient's head back up to neutral again. Now we're just doing that IA cleanup. Here's where I'm going to check and make sure that those haptics are in the correct location and they look great. We're going to get out as much blood as we can. If the patient was bleeding at the time of the insertion, I do try to hyperinflate them at the end of the procedure to avoid as much hyphema as I can post-op day 1. And so here you're going to see me doing a little extra hydration. Sorry, camera slightly out of focus, but that's the end of the case. Thank you for taking the time to watch it.